My name is Francesca, and I am an HIV and TB clinician. But before I embarked on the research field of HIV and then onto TB, I was a general practitioner for many years. I worked at Alex Clinic, and then I worked in a small practice in Johannesburg. So the subject of, and what is going to be the main subject of conversation today, is non-communicable diseases. I'm not going to be talking about the other comorbidities associated with HIV, for example, infectious cancers or cancers caused by infectious agents or other problems. I'm going to be focusing specifically on non-communicable diseases. If I compare what has happened in HIV treatment since I left general practice in the year 2000 to now, it is without parallel, I think, of any disease in the world. We've gone from a disease that almost everybody who got it ended up dying if it was untreated. And the way that we treated HIV from 1995 to say 2002-3 is that we gave our patients medicines for prophylaxis to prevent any of the opportunistic infections, but really we had very little else to do. And then along came antiretrovirals. Antiretrovirals first in the beginning had quite a lot of side effects, were difficult to take, once or twice a day. And then we've refined it down to, first of all, TEE, and then down to TLD, which are very, very simple medicines to take with a very low side effect profile. I remember very clearly when I started working in HIV all those hundreds of years ago, a patient came to see me. And in fact, he was enrolled on a clinical trial for one of the drugs that are now in our national program. And he told me that he was canceling all of his insurance policies. He was going to take the money and he was going to live wild for the next couple of years, if that, and then he was going to die. Then he was a little bit pissed off when 10 years later, he was still in excellent health. He was well, he was able to hold down his job, but he'd unfortunately cancelled all his life policies. And that's what we're seeing in HIV, is that it is, although still from time to time, we are seeing patients presenting with advanced HIV disease. Now it's really fitted into the realm of a chronic disease, and we line them up outside our offices, diabetics, HIV with diabetes and hypertension, and they're just all a pile of diseases that are now easy to manage in the chronic care setting. But the thing that I've noticed is that while the trajectory for treating HIV has gone through the roof, we're now even starting to think about using injectable agents for the treatment of HIV. The diagnosis, treatment, and prevention of non-communicable diseases has almost gone nowhere since I was in general practice. We're still using the same medicines pretty much for many of our non-communicable diseases. But more than that, the advice that we're giving to patients about non-communicable diseases hasn't changed all that much. There are a couple of highlights that I'm going to be talking about of what's new in the field, but we really got outmoded mechanisms for the treatment and prevention of non-communicable diseases. For those of you who've been in this field for the last 100 years, remember when our HIV prevention message was ABC: abstain, be faithful, and condomize. And you know what? It did not work. It didn't work for a number of reasons. First of all, sex is a normal part of our lives. This not paternalistic, this judgmental way of trying to prevent HIV just drove behavior underground, and people didn't confess to what was happening and their potential risk factors, and we couldn't really help. So those messages don't work. And I feel to a large extent the messages we have around non-communicable diseases don't work either. So with my first slide, just hang on a second. There we go. So the headline news is not only are non-communicable diseases responsible as you'll see in my later statistical slides, for probably 3/4 of the deaths in the world, and particularly premature deaths under the age of 70. So non-communicable diseases are a major cause of both morbidity and mortality. But unfortunately, HIV infection can increase the risks of non-communicable diseases and also can increase the behavior that puts it at risk of HIV infection or complications from HIV infection. And one of the ways that that works is by stimulation of the inflammatory markers. So we know that although we can repair the damage done to a large extent in an HIV-infected individual by giving them antiretroviral therapy, there's still gaps in the immune system and an increased inflammatory marker background that can increase the risks of NCDs. The adverse events associated with some antiretrovirals, we're getting to grips with them more and more. We've dumped a whole lot of really unuseful medicines that caused severe side effects. We've got a better profile in terms of antiretroviral treatment that we can give. But there is a link between the two that we need to be cognizant of. The second thing is that, as I mentioned in my story about a patient who cashed in his life insurance policies, we are now getting to the really interesting state where we're seeing the aging HIV population. Remember in those terrible dark days when people got HIV and died before they were 30? That's not happening anymore. NCDs increase with age. The risk and prevalence of HIV increases with age. And now we've got an aging HIV population as well. But the difference between the general population and the HIV-infected population is they come and see us. So they are accessing HIV care or medical care on at least a biannual basis. So every 6 months, they need to come and see us and we do something or other. We repeat the prescription, we repeat CD4s and viral loads. But the fact that they're interfacing with us needs to remind us all the time that we need to be looking for NCDs and doing what we can to prevent them, because we have got, in inverted commas, a captive population. We've got people who've come to see us who are buying into the medical system, and we're really doing our patients a large disservice by not dealing with their NCDs. So the topics that I'm going to be covering in this talk is, first of all, a rapid overview of the high burdens of non-communicable diseases. And then I'm going to give you some really good advice. Some of it is a little bit outdated, but I'm going to talk about unhealthy diets and obesity, physical inactivity, and what we need to advise our patients, exposure to tobacco smoking, and harmful use of alcohol, and some of the newer tools that we can use. Not all of them are all that helpful, but what I want to do in this particular talk is to remind us that there are things that we can do. And also the patients that come to see us are really relying on us for medical advice. So, as I mentioned before, non-communicable diseases kill 41 million people each year, and that's about 74% of all the deaths globally. Of course, COVID overtook that for a while, but we're now back to bog standard life, which means that 74% of people who die are dying most prematurely, so before their allotted time, because of non-communicable diseases. And of those 41, 17 million die below the age of 70. And what's often not recognized is many of these premature deaths occur in countries that we are all attending from. I know that there are Zimbabweans and Namibians, Malawians and South Africans on the call. We are low and middle income countries, and many of the deaths from NCDs occur within our populations, and there must be something that we can do about it. So what are the big NCDs that I'm going to be dealing with or covering a little bit today? The first one is the most common cause of death is cardiovascular disease, which is related to a number of comorbidities. The poor diet, hypercholesterolemia is the one track. The second track is obesity leading to hypertension, and then the effect of HIV itself. So this causes 17 million cases. Good news, power's come on, so I'm going to turn my camera on. There I am. In terms of cancers, cancer is increasing. We have methods of detecting cancer earlier, and please don't forget, for your patients who are attending your clinics, that there are things that you need to do. Women, particularly women who are HIV infected, should have a pap smear at a bare minimum every 10 years. In addition, younger women need to be vaccinated against HPV. And if women do not have antibodies against HPV, consider vaccinating them anyway, so that you can prevent the oncogenic strains of HPV causing cervical cancer in them. Then the next thing is chronic respiratory disease. And a main driver of chronic respiratory disease is smoking of alcohol. Drinking cigarettes, the other way around. So a major cause of chronic respiratory disease is tobacco smoke. And that affects not only the individuals who are smoking, but the people who are living around them. And then diabetes is another major NCD, and it includes, it causes death more often than not. It causes death by causing kidney disease, and this can be largely prevented by good control of diabetes. I was reminded today, I had a story, a nurse of mine actually said to me, her dad developed diabetes and ended up with pretty severe renal failure. But he had never been screened before. No one had ever suggested that this elderly man even pee in a bottle so that we could look for diabetes. And just as we've made HIV testing a norm, that people will go for HIV testing all over the show, we've got to also start screening for NCDs and instituting appropriate treatment, advice that can assist people and help them overcome. Okay, there's always a little bit of a delay. Okay, so the contributing factors I've mentioned already, unhealthy diets. And the one thing that I'd like to challenge everyone on, what exactly is a healthy diet? All I know is that a healthy diet is likely to be an expensive one. When we tell people that they need to move around, they need physical activity, how do we quantify that? Do people want to stop smoking, and what can we do to help them? And then what is the definition of harmful use of alcohol, and how can we help our patients overcome? The diseases are driven by the kind of ills in society that we're thinking. The first that's occurring not only in sub-Saharan Africa, I've recently completed a trip to India, and exactly the same thing is happening, is that there's rapid unplanned urbanization, that people are moving, they're voting with their feet to somewhere where they can earn a living. And agriculture is often a subsistence, and people will move to cities for jobs. And that is associated with less physical activity. And it's also associated with often less money being around, and therefore people not eating as healthily as we'd like to. And then, this doesn't only occur in my suburb in South Africa, but it occurs just about everywhere. And then our population is generally getting older. I think that the good thing about the countries represented on this call is we still have a pretty healthy younger generation who will hopefully come up with good ideas to solve problems, but also be able to support the burden of the older people like myself. So what happens when people don't eat well and have poor physical activity? Their blood pressure goes up, their glucose goes up, they get elevated blood lipids and obesity. And you only have to walk around a shopping center for half an hour and you will see just about everything that I've talked about. So let's talk about obesity. So obesity's definition is a body mass index above 30, or a body mass index also above 35 is morbid obesity, and we see it. We see it all around us. And then, of course, the risk factors for disease, for obesity, obviously, if there is anything else, for example, uncontrolled diabetes or hypertension, that also increases mortality. Why does obesity increase mortality? So what's the problem, as it were? People don't move around, they get hypertension, it becomes a vicious circle. And much worse than that is that we blame people who are obese. We think of them as, or there's a new cultural norm of being careful not to body shame. But all of us, if we're honest, if we see someone who's really overweight, our instant reaction is, sure, you're lazy. And we have to guard against this kind of thinking, because obesity is as a result of overconsumption of food. That's a given. But there are certain metabolic processes that make it much more difficult to reverse. Human beings, or Homo sapiens, were actually born to adapt to scarcity. We were born to live in a world where we would not have too much food, and we would chase after the food that we actually wanted to eat. And things have changed. That lifestyle is gone, but unfortunately our metabolism has remained the same as it was in the days of scarcity. So we tend to put on weight if we don't have the physical activity and good eating habits that is required. So I think one of the take-home messages I want people to take from this particular session is, let's not blame people. Let's not judge them. Let's assist them. ABC didn't work, and ABC didn't work because it was judgmental. And the last thing that we need is to drive people's behavior underground. Let's rather think of ways to assist them to lose weight in a better way. There doesn't seem to be much difference in the risk factors for obesity in HIV-positive adults. And it seems to be roughly the same. And the outcomes of obesity, which is premature death, is the same in HIV-infected adults as non-infected adults. We do worry about the drugs that we are giving, because in the greater scheme of things, the drugs that we are giving for in antiretroviral therapy are pretty new. Dolutegravir has only been registered for about 10 years. And the original drug trials for dolutegravir were not conducted in our population group. And the greatest burden of being overweight is borne by Black women. And the drugs weren't necessarily trialed in Black women. We've had to re-look at it and make sure that we are not missing anything. What we do know is that obesity causes an increase in cardiovascular disease, and we just don't have enough data to say whether this is going to occur because of the effects of integrase inhibitors. So what does obesity do? And obesity and HIV together. The first thing is it causes hypertension. Hypertension is associated, and if you didn't know all of this, then you're in the wrong talk, is associated with strokes, more commonly in the Black population, or ischemic heart disease in other population groups. The development of strokes when people develop strokes, we don't have the best rehabilitative facilities in the world. Often people who have strokes then end up not being able to function as well as they did before. They lose their jobs. So it's something we really want to prevent. Diabetes is, so type 2 or non-insulin dependent diabetes is also caused by obesity. And that has far more side effects, or far more adverse effects than insulin-dependent diabetes, often because it's diagnosed very late, as I talked about in the case of my nurse today. And it's associated with retinopathy. Going blind is a huge disability in South Africa, or in sub-Saharan Africa. It's associated with peripheral neuropathy, and we kind of attack our patients' nerves from a number of places. Although our antiretroviral therapy has got much better, it's still a potential, and many of our TB drugs can cause peripheral neuropathy. You're right, there won't be a single talk given by Francesca that I do not mention TB. Of course, bearing extra weight on joints that are not supposed to bear that weight causes osteoarthritis, and while that might be repairable by repairing joints, that is not available to vast portions of our population. Obesity is also associated with malignancies. It's associated with fatty liver disease that can cause liver failure, and pregnancy in a woman who is already obese, a BMI above 30, is associated with a number of complications, including the ones mentioned, and hypertension in pregnancy. So why do HIV-infected individuals gain weight? So our bodies have a kind of a set point where our weight is supposed to be. If something damages your health, often that set point is reset at a little bit higher, because what is happening is your body is saying something really bad has happened. I've got to prepare for it happening again. And as people return to health, they may increase their body mass just because of the metabolic effects of being sick. There is some evidence, although not all that much, that dolutegravir is associated with weight gain, although it seems to be more associated with weight gain when given with TAF as opposed to tenofovir. And it does seem that this is a little bit inhibited by tenofovir. I think that in amongst the other causes for obesity in HIV-infected individuals, it's exactly the same as everybody else, that people eat too much, they ate too much of the bad food, and it's a vicious circle that they gain weight, therefore they have reduced physical activity, and therefore they gain weight, and therefore they have reduced physical activity. I think that the one thing that we need to stress is that moving around a physical activity is vital for good health. It reduces inflammation. It improves cognitive ability. It probably has the same effect for mild depression as many of our antidepressants. But you can't really, to lose weight by exercising, you have to wake up and start running and then stop running just about when you go to sleep. So physical activity is an adjuvant to weight loss, but it really is not the only thing that one needs to do to reset the balance. So there is a link also between how much people gain weight. It's kind of inversely proportional to their CD4 counts. So the lower the CD4 count goes, the more likely they're to gain weight once it recovers. What do we do about that? Is early diagnosis of HIV. And we are finally getting this right in South Africa. Well, not finally. For the last 10 years, we've normalized HIV testing, normalized treatment, that it's just one of those things that happens here. Take this medicine, these are your side effects and what you need to watch out for. But I think we still unfortunately do see single or double digit CD4 counts presenting to us. Advanced HIV disease is often associated with profound weight loss. In fact, HIV used to be called the SLIMS disease, and it is also associated with increased metabolic demands. And when we stop that, and we stop that by stopping viral replication, then this energy is then channeled back into weight gain. And in addition, our wonderful antiretroviral drugs are associated with alleviation of HIV-associated inflammation. I remember when I used to treat children, when we still had that many children infected, that almost within a day or two of initiating antiretroviral therapy, you know, kids are simple beings, that you treat them and they start to feel better and you know it. And we could see children improving to health very soon after initiation of antiretroviral therapy. I'm hoping that as we're getting closer and closer to our goals, that we are starting to eradicate pediatric HIV. So hopefully we won't see that much. Also, when you treat HIV, it helps to resolve opportunistic infections. That's why we have an immune reconstitution inflammatory syndrome. So we have IRIS, but also many OIs are treatable with antiretrovirals alone, and this improves, so it resolves people's appetite, improves, and the food that before was just rushing through and going out the other side is now being properly absorbed. All good things, by the way. So is dolutegravir the evil that we thought it was? Do we really need to reconsider our decisions about our placement of dolutegravir in our antiretroviral program? And I want to say the first thing is dolutegravir is one of the best things that have happened. And although there's a small signal about weight gain, it is still far outweighed by the low side effect profile, the ease of administration that has made this our standard of choice, our treatment of choice. In a study done by my dear friend Francois Penter called Advance, he compared 3 antiretroviral regimens, our TLD or TFD, TXD, I suppose is a way to talk about it, and then tenofovir alafenamide or TAF containing regimen. And that was compared to our then standard of care, which was tenofovir, FTC, and efavirenz. And if we have a look at the weight gain that occurred, is that, I might have missed a slide here, is that we saw, I beg your pardon, everyone who's watching, is that women who were on TAF gained up to 10 kilograms. And that, if you think of a person's average height at being, say, 1.5, that means that every 10 kilograms of weight pushes up your BMI by about 3 points. So if you were sitting at 25, you'll be pushed to 28, which is close towards going to the obese range. When we used dolutegravir alone, women gained, they gained 5 kilograms, and when efavirenz was used, they gained only 3. But men who have different metabolisms gained only about half as much as that. So even on a TAF-containing regimen, while they did put on weight, they didn't put on as much weight as women. There is an intrinsic difference in the way that genetically or a person born female handles drugs and diseases versus those who are born male. And that's something we need to be cognizant of. So what we found is that the rate of weight gain was inhibited by tenofovir and efavirenz, and it was different in men and in women, and it depended on the CYP2B6 phenotype, and depending on which one they had, they might be slow or rapid metabolizers, and that would affect their weight gain. Does it affect what we do in our general practice? No. We are still saying that the TLD is our best regimen this far. I know this talk is being recorded, and maybe in 5 years' time it'll get played back to me and they'll say, you didn't know about this. We now have something new and different. And it may well be the injectable agents. So if we have a look at the changes, we look at the differences between men and women, and as mentioned before, what happened is that while weight gain was substantial, it was less in men than in women. Doesn't mean we need to throw our hands up in disbelief. It does mean that we need to discuss this with our patients and talk about how to prevent excessive weight gain right from the get-go. So what do we do when someone comes to us and says, I've now gone from a dress size of 32 to a dress size of 42, please help me? Does it make sense to change them back to an efavirenz-based regimen? I think that often what we will do is we will try anything for our patient. So long as the patients are adherent to their therapy and you swap the antiretroviral at the time with a suppressed viral load, this change is not an unsafe change, but again is associated with the development of potential neuropsychiatric side effects, which is why we dumped efavirenz in the beginning. And you can say to patients, this is a negotiation. The data is showing this might be drug-related. So what about we change you back? But if you're finding problems with neuropsychiatric side effects, don't worry. we can get you back to dolutegravir without any loss of efficacy. The other alternative is to consider the other NNRTI, rilpivirine, which in my mind has been a drug that has not really gained the traction that I think it should. While it's not safe with TB treatment, yes, TB always comes up. While it's not safe with TB treatment, it is a low molecular weight and a very safe drug to be used. Not co-formulated yet, I don't think. So it might add to the pill burden. But I think when you've got engaged patients, you can sit and talk about what the options are and what the benefits and risks are of changing. I think that if we look through the history of mankind, there's a cultural sensitivity about about weight. If you look at the painters in the 16th to 17th century, they painted these huge, voluptuous women who were borderline obese. And that was seen as a sign of having a good lifestyle, being healthy and well. And we know that in South Africa, well, in sub-Saharan Africa, that being underweight is associated with people thinking, I wonder if she doesn't have HIV. So we've got to be sensitive to this, but at the same time, we have to bear in mind that this being obese or morbidly obese comes at a cost of other health issues. So we've got to be sensitive. We don't want everybody to look like the stick models that walk around and show off clothes, but we've also got to be aware of how people feel about weight in general. So take home messages from the obesity section. Quit being so judgmental. Help people and also address, it's a horrible word to use, but address the elephant in the room. I want to talk about a patient of mine who was diagnosed with HIV when she developed pericardial TB. She spent a good 2 weeks in ICU, and that was touch and go for quite a while. She responded beautifully to antiretroviral therapy, and within 2 years was back to her normal functioning, a CD4 count above 400 and an undetectable viral load. But every time I saw her, she gained a couple of kilograms. Remember, I was seeing her every 6 months. So by the time, after I'd known her for 10 years, my patient was morbidly obese. And yet I had difficulty in broaching the subject. I'd say, let's talk about losing weight. And she sort of brushed it off because she'd had a brush with death. And to now be concerned about some extra kilograms really didn't seem to get it onto her agenda. And more importantly, it didn't get onto my agenda to really push the issue home. She then had an episode of chest pain, was seen by another cardiologist who told her her cholesterol was high. And she got such a fright that she started she started limiting the amount of food that she ate, and I'll talk about that in a second. But it took another health scare for her to change her behavior. And she lost the equivalent of 50 kilograms by lifestyle changes. She was very motivated, has 2 lovely daughters who kept nagging her about it. But she talked about the things that she did in her life that were unhealthy. Every payday, she would go out and treat herself to Spur, to Wimpy, to Nando's. Well, Nando's is not that bad, but it was like a reward system. And we know that this is true. That's why we call it comfort food. And just by limiting those options, and she started to move around a little bit, she managed to lose a huge amount of weight. A very, very motivated patient. And unfortunately, many of the patients we see are not as motivated as this particular one. So what is a healthy diet? The first thing, and it seems to be pervasive, is the best way is to start a healthy diet earlier. In fact, babies who are born small for gestational age have a higher risk of developing diabetes as they get older. But breastfeeding is the perfectly balanced, and it's the best thing to feed babies. And when you are seeing moms, just remind them that it's worth sticking breastfeeding out because it's a really good thing. Obesity occurs, or weight gain occurs, when you take more calories in than you expend. Now, it's very difficult to work on the other side of the equation, the energy expenditure, but we have to look at ways of decreasing calorie intake. Ways to decrease calorie intake is, first of all, that we should try and decrease the amount of fat that we eat. So fat associated with fatty meats, oils, butter, we should try and limit that to less than 30% of our total daily energy intake. It's quite difficult to actually do the sums, but we should be aiming for grilled rather than fried, mashed potatoes without butter rather than chips, to try and counterbalance the amount of fat that we eat. We should also decrease the amount of saturated fats that we take in. Saturated fats are in animal products, so we should try and reduce the amount of animal fat that we are consuming and reduce the amount of trans fats that we are ingesting. Those are manufactured, really. The other thing, and it is something that governments in the world are generally getting onto, is that probably the biggest culprit in our diet is not actually fat, but it's in fact sugar. Who feels miserable and goes and buys a bar one? I'm raising my hand. And not only, so that's clearly a sweet, but a lot of food has added sugar. And once you start looking at labels, you will be shocked. The way to decrease the amount of sugar that people have in their diets is, first of all, don't add anything. So don't add extra sugar. Get into the habit of drinking tea and coffee without sugar in it. It's doable. I know I do. In fact, I much prefer it. And then eat food as close to the source, as close to the way it was created as possible. So the more processed it is, the more likely that there is to have sugar added. And we all know that now drinking fizzy drinks with sugar in is more expensive than no sugar. They taste the same. So I think that we've become really conscious of refined sugars in our diet. Not part of a healthy diet is also decreasing salt intake, but that's kind of a little bit off the subject. So this is the advice that the WHO gives us. And we should eat portions of fruit, vegetables, and legumes, and we should eat at least 5 portions per day. We need to exclude potato and sweet potatoes, cassava, and other starchy roots. And if we are going for fruit and vegetables, please note that processed maize, which is the backbone of many of our diets, is excluded from this list. Decrease the amount of sugar, then take the free sugar out of everything, cook from as much as possible. Don't eat too many saturated fats. So concentrate on eating fish, avocados, nuts, sunflower, soybeans, canola, and olive oil. All I know is what this ultimately adds up to is a lot of money, and it is not useful to the vast majority of patients that we treat. This is the kind of diet that we would suggest to someone who has a Woolworths down the road and a credit card. But what advice can we really give to our patients that is useful? To tell them 5 fruits and vegetables a day, don't eat milli meal, is not advisable. But I think that, it's just not doable. People will look at you and thinking, she's smoking her drinks or whatever she did with her alcohol. She just doesn't know what she's talking about. So what advice can we give? The first and easiest and lowest hanging fruit is to tell people to decrease the amount of refined sugar that they are having in their diet, and to be aware of it, to know that if you're buying processed food, there is sugar in there, and to try and decrease the burden of that as much as possible. To eat smaller portions, obviously, and then, but try and get appropriate advice for the people that we are working with. But finally, and I know that this is not currently in the reach of average people who live in our communities, But we finally come across a diet drug that actually works. So it's currently out of stock almost everywhere in the world because it is so effective. But this drug, Ozempic or semaglutide, is a GLP-1 receptor antagonist. So what it does is, the reason that we all stop eating is because we have GLP that goes through from our stomachs into our duodenum and tells us that we are full. And what's happened is that we have learned to override that. We have learned to eat until our tummies are really full. We've also learned to eat bad stuff so that that satiety, we can eat really high calorie stuff before that satiety kicks in, and therefore we've overridden it. Obesity is an epidemic, and this is the first potential drug that could help with that. At the moment, it actually appeared on the front of The Economist, which is a non-medical journal, as one of the potential things that we could do. Shouldn't be prescribed to people with eating disorders. It shouldn't be prescribed to anxious people who just want to lose a bit of weight. But when you've got a person who comes to your office with a BMI of 35, they really need help, and this is a useful drug. It's been associated with weight loss of up to 15%. So if you weigh in at 100 kilograms, the average person using Ozempic per year will lose 15 kilograms. Now, it won't continue. It will kind of balance out when our systems have finally readjusted. What do we do with this piece of information? This is out of the reach of many of our patients, but we need to start advocating for these kind of drugs to be available, and for us to quit this judgmental way of dealing with obesity. You're a fat, lazy slob. No, our metabolism has set us up for failure in the year 2023. My advice has been useless. Go and buy avocados and salmon from Woolworths. This is at least a way that we can help our patients. Keep an eye on this. This is where the action is going. So we've talked about weight. We've talked about what advice to give our patients in terms of diet. Obviously, we're adjusting it to the people who live in the communities that we serve. And now we're going to talk about physical activity. You have to exercise really hard to be able to lose weight with exercise alone. In fact, it's impossible. Every now and then I do a comparison between what my Apple Watch tells me, how many calories I've burned, and how much an apple contains. I'm telling you, it's a huge workout, burns up half an apple. So it's obviously we've got to get a balance. But what we do know is that physical activity is good for you. Remember when we were in lockdown and we weren't even allowed to go out and exercise, how miserable we all felt. Of course, there were a lot of other reasons for why we felt miserable, but exercise does improve people's cognitive abilities and decreases it gives us endorphins. So when we say to people you should be physically active, what do we mean? This is advice from the WHO, and there are recommendations for adults between the ages of 18 and 64. And I think that's almost everybody who's on this call. First of all, we've upped the amount of exercise that we should do. Discovery Medical Aid has come up with this 10,000 steps. It's probably not enough. What we need to advise our patients is 160 minutes. So that's 2.5 hours of moderate intensity aerobic exercise throughout the week. So it doesn't mean, I suppose you could do 2.5 hours in a day if you wanted to, but what we need to do is so people say, I'm physically active. I sit at my desk, but then I jump up and walk around. That's not enough. The physical activity has to be of moderate intensity. And it's a good idea to climb the stairs if you're working on the 5th floor. That's a good idea. But it doesn't really count all that much in terms of the advice we're giving for physical activity. Then we need at least 75 minutes. So that's 1.25 hours of vigorous intensity aerobic exercise throughout the week. And exercise only counts if you do it for 10 minutes. So if you walk up the stairs and you're working on the 5th floor, that's going to take you 3 minutes to walk up. It's not going to add to this 75, 150 minutes of aerobic exercise. It needs to be concentrated aerobic exercise that the benefits only start to kick in once somebody has done it for 10 minutes. Of course, we are also concerned about osteoporosis in our now thankfully aging HIV population. So we do need to do muscle strengthening exercises, and that can involve going to a gym or various other activities that don't involve spending money, that can strengthen various muscle groups, particularly focused on the core, which helps us. And now I'm sitting up straight to remind everybody to sit up straight. So when we're saying to people exercise, this is what we mean. Sweetie, what you need to do is to go for a vigorous walk for 2.5 hours every week, or a run, or a cycle, or a swim, or anything that gets your heart rate up above and into the zone, I forget what they're called, but gets your heart rate going. And some of it must be vigorous. Your heart should be pumping if you want to get the benefits of exercise. My patient who I described, when she originally came to see me, she could not walk around the block. Now she's participating in the Run for Life, all kinds of exercise programs. Encourage your patients, if they're in areas that they can be involved in community activities. There are various walks that are arranged, and it's nice to get together as a community. Of course, we don't for 1 second want anyone to get hurt at all. But think of things like telling your patients, if there's a park run in the area, go and do it. Why don't you gather a bunch of friends together and commit to walking for 75 minutes and make it a positive thing? So we've talked about what we do when we are seeing patients gain weight or overtly obese patients, the advice to give tailored to what they need. Decreasing refined sugar is really high on the list. And then to encourage people to have concentrated physical activity, not just I jump up from my desk and walk to the printer 3 times a day. That's not enough, but to focus on exercise for all the reasons that I've mentioned. Pardon me, I'm talking so much, my mouth has got a little bit dry. So the third most common driver of NCDs is exposure to tobacco smoking. If you don't know that smoking tobacco is bad for your health, then you are on the wrong call. So not one cigarette is okay. So it's in contrast to what I'm going to tell you about alcohol shortly. But smoking causes an increase in just about everything. So it's associated with clearly lung cancer, but almost all cancers are higher in people who smoke. Heart disease, stroke, lung disease, and COPD must be one of the worst medical conditions in the world, because people, they just kind of fade away because their lungs aren't working anymore. It's a terrible thing. It's really not a good situation. And the link between COPD, emphysema, and chronic bronchitis is so clearly towards smoking. And then, of course, you're in a talk with Francesca Conradi, so I'm always going to raise this issue, that smoking actually increases your risk for developing active tuberculosis disease. I'm simplifying this a little bit, but what we do find is that more men get TB than women. And there are lots of contributors to that. But one of them is definitely that more men smoke than women. For a whole lot of cultural reasons, it's more acceptable for a man to smoke. And it's one of the reasons that we see a male predominance. Also, men are more likely to have occupational exposure, and sadly, more men are incarcerated than women, which is another risk factor. But smoking makes you more likely to get TB. Smoking damages your lungs. TB damages your lungs. So we see patients who've become respiratory cripples because the combination of the damage done to smoke on top of fibrocavitary disease has rendered them oxygen dependent. Very, very poor quality of life. So what do we do about telling people to stop, telling people? In a survey done of the 1.33, first of all, there are 1.3 billion tobacco users worldwide. So that's about 1 in 4 people in this world smoke. But when they've done studies in not only in sub-Saharan Africa, but all over the world, the vast majority of people who smoke actually want to quit. They actually do want to stop, but they don't stop for a number of reasons. First of all, they want to quit partly because of health-related issues, also causes wrinkles, it makes you cough, it costs money, and many people actually want to stop, but we don't really have good tools to help people stop smoking. I'm going to talk about one of the medical uses, but it's really not widely used and not that effective. In South Africa, we have a pretty progressive tobacco control program. Every year when the budget is announced, they talk about the sin tax and they increase the amount of tax on cigarettes so that the cost of cigarettes is disproportionately, it's higher than inflation. So that's a good thing. We've got pretty robust non-smoking laws. When I was a kid, you were allowed to smoke in movie theaters, you were allowed to smoke on aeroplanes and in restaurants. And now we know that that's largely been removed from many of our public places. It hasn't made that much impact on the incidence of smoking-related morbidity and mortality. Maybe it's still to come, but we haven't really made an increase in stopping people smoking. Neither did our rather strange ban on tobacco during the early days of COVID. I think what it did do is it drove the black market. And it was, in my opinion, an unfair thing to do. Not only were all of us stressed, but the smokers were even more stressed than anyone else because we thought the world might end and they thought the world might end and they were anxious. So I'm not sure that it made all that much difference. So what can we do? Of the people who go to doctors or nurses or healthcare professionals, you know what? We forget to tell them smoking is bad for your health. I am a non-smoker. I've never smoked in my life. But so if someone is in my consulting room and they smoke, I know it because I still got this very active sense of smell. And I think that often we kind of skip over it because our patients do have a lot of problems and we think, oh, we can't add this. But sometimes the thing that tips people over to become non-smokers is a doctor or a nurse telling them this is bad for your health. And in your particular situation, I'm a TB doctor. In my particular situation, this is bad for your health because it's making your lungs even worse. And, you know, I can treat your TB, but, you know, this damage is going to become irreversible one day. And people often tell me that the thing that kicked them over was a doctor actually reading them the Riot Act or a nurse saying, not, you know, I understand this is difficult to do, but you do need to stop smoking. What medicines do we have? There are a whole miscellany of nicotine replacement therapies. There's gums and patches and ways to use it and advice that we can give our patients that do definitely help. What they're addicted to often is, in fact, the nicotine. And if we can replace that with out of all the stuff that comes within cigarettes, this is a safe thing to do. Wellbutrin was a drug, also, I think its trade name is Zyban, that does have some use in a 12-week course. It's also an antidepressant that can help. But ultimately, what we need to tell our patients, this is bad for your health, and stop hanging around smokers. You know, don't go out for a drink and a smoke, and try and give them advice to help. I've been universally unsuccessful in this. I think that because I've never been a smoker, I don't really understand why somebody would do that. But we do need to remind people that smoking is bad for your health. I'm not sure that pictures of fuffy lungs really makes a difference in people's health. But I always go for the things that, do you know that smoking causes vascular disease? And vascular disease can cause erectile dysfunction. Think about that. You know, we kind of pull the guilt trip on our patients to try and assist them with better health-seeking behavior. So let's talk about alcohol. alcohol is associated with both morbidity and mortality. And in South Africa, when we had the lockdown where alcohol sales were decreased, we saw a massive decrease in visits to hospitals, particularly trauma-related. So, I mean, if you have any doubt that alcohol is benign, it's not benign. How does the WHO define harmful use of alcohol? The first thing is that it's drinking that causes detrimental health and social consequences for the drinker themselves. So if people are getting drunk and then forgetting what they did, doing things that they wouldn't do when they were sober, that is harmful drinking. If it's making a pass at your boss or doing something that you know that you wouldn't do when you're sober, that's harmful drinking. Harmful drinking is also when the people around you are harmed by your drinking. So if you're drinking so much that it's causing anxiety or even breaking up your family, this is harmful drinking. It causes harm for the society at large. So drinking and driving. The amount of gender-based violence and just plain old violence and stupid things that happen when people consume alcohol is a societal harm. And if you are drinking that, you're causing society at large to be harmed, that is harmful. And we estimate that there are around 2.3 million deaths related to these harmful effects. So either accidents, violence, or the diseases that are associated with the high alcohol use. So when I was training as a doctor, people were defined as they were alcoholics or not. And you were an alcoholic if you had withdrawal symptoms, if you drank more and more, if you got the shape. So that was a definition. But in fact, most people who drink excessively are not alcoholics. They're not even alcohol dependent, because if you tell them to stop drinking, they will drink without withdrawal. They'll stop drinking without withdrawal. If you've seen someone who has withdrawn from alcohol with a delirium tremens, it's a very scary condition. And in fact, going cold turkey from alcohol is much more dangerous than going cold turkey from heroin or opioids. Those cause these sort of vague physical symptoms, whereas DTs is a really severe illness. But what is defined as binge drinking? Unfortunately, men and women are different. But for women, if they drink more than four or more drinks in a single occasion, so that means that you're a binge drinker if even over a month period, you have one bad binge where you drink 4+ or 5+ drinks on a single occasion. Obviously, it's got to be recurrent before we're really worried about it. We all go to happy occasions and weddings, have maybe one glass of champagne too much. But, if this is a recurrent pattern, and it is a cause of significant morbidity. Hangovers are one of the most awful things that can happen to a person, and it's self-induced. So the short-term side effects, but also the long-term side effects of binge drinking. For inhibition control, so people do things that they wouldn't normally do. You are considered to drink heavily if you drink more than 8 drinks per week if you're female, and 15 if you're male. I didn't write this. This is written. Women do not metabolize alcohol as well as men. So drinking in moderation. If you should drink less than 1 drink per day if you're female, and less than 2 if you're male. I think that we start to see alcohol dependence and issues occurring when somebody always drinks every single day, even if it's only 1 or 2 glasses. And it's something that needs to be addressed. Who should not drink at all? So children or people under the age of 21, for a number of reasons, they should not be drinking. Pregnant women, we're perhaps a little bit strict on this because fetal alcohol syndrome is associated with real overindulgence in alcohol. But we advise women who are pregnant or think that they might be pregnant not to indulge in alcohol. Then the reason I've highlighted this is that you shouldn't be drinking If you are involved in activities that require skill, coordination, and alertness. And this is normally applied to driving or operating heavy machinery. But one of the things that puts particularly young women at risk is sex requires skill, coordination, and alertness. In order to have consensual sex, you need to be awake and be able to give consent. And much of our inhibitions disappear when we are under the influence of alcohol. And I think that it's one of our HIV prevention messages that we need to get out there, is that gender-based violence is never right, and it is never the woman's fault. It is never the person on which the violence is being perpetrated. But women can get themselves inadvertently into trouble. They can get into situations that their normal sober mind would not do. So warn people that overindulge in alcohol can put you at risk. And if you're going to overindulge, you know what? Get a non-drinking buddy to make sure that you are safe. Again, we need to be not judgmental. We need to help people to indulge safely. If you're taking certain prescription medications, and the one that's very common is metronidazole, which has an anti-abuse effect. If you want to stop people drinking, give them a dose of flagyl. They'll not feel very well. Some over-the-counter medications do have alcohol in them and probably shouldn't be co-prescribed with, well, people shouldn't drink as well. So one of the definitions, and there are many of them, of being an alcoholic is unable to control the amount that you drink. So some people can have a binge and then not drink for months on end. And often it's the after effects of the binge that stops them, that they had such a terrible headache, they puked for 2 days. But some people, once they start, they cannot stop. And that's one of the definitions of alcoholics. And those people cannot drink at all. So they have and it's probably a genetic issue. I don't know what it is, but there are some people who cannot drink at all. And we live in this society that is steeped in alcohol as a form of socialization. You can't have a party without having a whole lot of alcohol. And people almost judge you if you say, no, thanks, I'll just have soda water. Be careful that you are not one of those that tells people that they're a wet blanket because they don't want to drink. These are choices and health-related choices. So the WHO has come up with a fairly useful tool called Assist to screen for harmful substance abuse. I'm not going to go through it page by page because, amongst other things, it's now 7:10, and I'm sure we don't want to go through all the questions involved. But it is a very useful tool to use to broach the subject of substance abuse. And now I'm not only talking about alcohol, I'm talking about any substances that are potentially addictive, to go through it with people and help people to self-score. And sometimes you see people and say, do you know that it's not actually normal to drink a half a bottle of wine every day? Well, it's not that it's not normal, it's not good for your health. And it's only when you point out that people are drinking every single day that they realize what's actually going on. I forgot to put the link to this, but there is a link to the WHO site. And this is a very, very useful tool to help people identify that, and often to help identify the behavior that puts them into trouble. So in conclusion, before I get to any of the questions and answers, is that, you know, in the height of untreated HIV, it decreased our mortality, it decreased our life expectancy in South Africa and in sub-Saharan Africa. That so many people were dying so young, including children, that it actually had an impact on the length of life that one would expect somebody to live. Now we've got good preventative tools, we've got good treatment, and U equals U, so undetectable is untransmissible. So we have a way of controlling the spread of HIV, and we are looking forward to an AIDS-free generation. But the people who cashed in their life policies 20 years ago, you know what? They're still walking this earth and they're well with the medicines that we're giving. So just as in the general population, we're seeing an increase in NCDs, we're also seeing it in amongst our HIVs. Our HIV-infected patients. There is an interplay between HIV and non-communicable diseases. And it is important that we as healthcare providers provide good advice, good non-judgmental, helpful advice for people to control their very difficult control conditions, And I think that I've gone through them all. And with that, I think I'm going to end.
Yes, thank you very much, Dr. Conradi. What an important topic for modern day. I think we are all affected somehow. I actually went on scale last week, and by just seeing the weight, I had a phobia to calculate my BMI. I thought, oh, I don't think it will be anything less than 25. So yeah, thanks for the topic and for the advice. So there's a number of questions, but let me start with one on a lighter note. Someone was asking to say, what about hookah or hubby? People, it's now very popular to especially in these parties and stuff. And I've seen lots of pictures on social media, people pulling and having fun. That regarded the smoking, or what can we expect from that? Yeah.
So it's somewhere. So vaping also fits into the same thing, doesn't it?
Yes.
So it's a potential. It's got less nicotine in it. The problem with smoking hubbly is that it depends on what's in there. Because it can be anything from just a nice flavored coal that's not too bad, but sometimes there are actually drugs in there. So they're actually things that are mind altering. Ultimately, it's better than smoking, but it's certainly worse than nothing. So it's not totally benign, but it's not as bad as cigarettes. I hope that kind of makes sense.
Yes, especially when you say it's not better than nothing. So I think there is some risk, and it depends on what people put in there. And linked to that question was a comment around snuff. I think that's Dr. Mohammed saying he sees a lot of his patients who take snuff, and there isn't a lot of studies or even reports around, I don't know, snuff versus tobacco, and are we expecting the same effect or outcomes?
So snuff, so the reason people use snuff is because it's got nicotine in it, and that's what they're getting from snuff. It doesn't cause quite the same amount of pulmonary complications, but it is also not benign. It's associated with head and neck cancers and problems with the upper airways more than the lower airways. So again, it's one of those things we don't really have that that much advice. It's not good. It's not as bad as smoking, but it's not good either.
Yeah. And then the drugs you referred to, Ozempic, I was just trying to link down on it. Is it available in the country, and can it be used with the commonly used antiretrovirals or even TB treatment?
Yes.
Any interactions? Sure. Yeah.
So TB is usually not. People who get TB are usually not overweight, but it doesn't interact. So Ozempic, the semaglutide, there's another one, liraglutide. I might be pronouncing it incorrectly. They are available in South Africa. They're 2,000 Rand a pop. So it costs you 2,000 Rand a month. They are available, but difficult to get a hold of because they've become really popular. They are very, very effective drugs, and they are very, they don't interact with everything. They don't interact with virtually anything. So they can be safely co-prescribed with dolutegravir-based regimen. I'm not sure how much work has been done with rifampicin, but they're very clean drugs. People are only on rifampicin for 6 months, and then afterwards. So it is available. At this stage, it's not reimbursed by the medical aids, but that's going to change because medical aids are medical aids are seeing the burden of obesity. And it's much better to help people reduce their weight than for them. It's cost effective. 2,000 Rand is cost effective. And I think it will come back down again.
Yes.
So someone commented, so liraglutide is not called Saxenda. It's called Victoza, or they're different doses. There is available. The differences between the two is Ozempic or semaglutide is given once a week. Liraglutide is given every single day. So that's the main difference. And semaglutide is more effective than liraglutide. They are available. But I think that it's a little bit pie in the sky kind of stuff. But I think what it is finally doing is it's changing our mindset. It's talking about obesity as a disease, something that requires treatment, not wrapping over the knuckles, you fat slob, which is in no way useful to anybody.
Superb. I saw something, so maybe let's go to, then we'll come back to Sarah's question. What about dagga, cannabis?
Yes.
Yeah.
So I work in quite an impoverished community in PE. And if someone pees on the stick and they don't test positive for cannabinoids, I think they've borrowed someone else's urine.
Oh.
It's very, very common. So what does dagga do? It's not as harmful as alcohol. That's the first thing. So alcohol is associated with decrease in inhibitions and aggression. And we know that. We've all seen bar fights and all kinds of things that have circulated. It's not as bad. It is also often mixed with other stuff, so it can cause problems with the actual inhalation. It's not as bad. We prefer people not to use it. One of the things that dagga does do is it takes away our drive, our passions, our strengths. And often people use a lot of dagga, and that's probably why they do it, is because life is miserable and you just, you can just let it pass over you for a while.
So it's for coping.
Yes.
Yeah.
It's for coping. And I think, it's very easy to judge the way that people cope, but life is extraordinarily harsh. It's been harsh for a long time. COVID made it even harsher. Then load shedding, the cost of living, the cost of petrol, unemployment.
Yes. It's quite difficult. I can't even imagine being a young person at the age of 35 towards 40 with your qualifications, but you have never worked, still staying with parents, having to ask your parent for airtime money. Yeah, sometimes we judge too quickly, but if you try and empathize, you see how difficult life is for many people. Yeah.
I think what you're saying is that many of these problems cannot be solved by healthcare professionals or by medicines. They actually will be solved by when we solve and hopefully we will sometime, inequality, poverty, all the things that go with it.
Very complex. Sarah is saying she understands the presentation, but then she wants to understand in a layman's language, how does she communicate the issue of total energy intake? I would prefer to talk about the food rather than energy itself, but I don't know, what's your advice? Yeah.
So I think that we know that some food has got more energy in it than other. A glob of butter is very high in calories, whereas popcorn, for example, I saw someone talked about popcorn lungs just now, has far less. So talk about energy-rich foods and reducing those. And so talk about decreasing the amount of oil that you put on food or butter that you put on food. It's quite difficult. And I think that if you're going to take a proper dietary history, you need to ask people what they actually are eating. And then say, this thing that you're doing, having deep fried fish, let's try and alter that to maybe grilled or something. That is also balanced against the fact that I have a couple of friends who I'm convinced have eating disorders, and they count every single calorie that they consume. And that's also a little bit obsessive because, tomorrow it's Friday, I'm going out for chocolate cake. Saturday, back on my bicycle. So it's we've got to have a balance about things.
Yeah, Kibita Mang at 7:13 there talks about a WhatsApp health check. I think she's trying to convert the TB, there's a TB check app thing on WhatsApp.
Yes.
And maybe we need to have something similar for NCDs. I'm not sure. I'm just trying to interpret that question. I don't know the impact that would have on people screening for NCDs. I'm not sure if you can screen just using questions. Actually, you can. Yeah.
To try and bring across the concept, and BMI is by no manner a perfect measure. And in fact, lower BMIs are associated with mortality for another reason altogether. But to try and bring say, if you are 1.75 meters tall and you weigh more than 80 kilograms, you probably are overweight. And help people to calculate and understand, because everybody knows that a short person weighs less than a tall person. And to try and bring that home. I think that, TB Day is next week on Friday, I think. 24th.
Thursday, yeah.
Okay.
24th is it not Friday? Yeah, but somewhere there.
Friday. Yeah. And I think we first of all made HIV testing normal. We sort of you can pop into the pharmacy and get it done. You can do it yourself. We have drives and we test. We never approved of the ex-president who said he tested and then disclosed his results. But so we've made that normal. We're now starting to normalize screening and testing for TB. If you're coughing, chest x-rays, et cetera, Now we've got to line people up and say, I think you should test for HIV. If you're coughing, I want you to spit in this bottle. Then I also want to take your blood pressure. I want you to wee on the stick and I'm going to prick your finger for cholesterol. And then with the same non-judgmental, we'll say, okay, so you do have blood pressure. Here's your pills. See you again in 6 months' time. And just make this kind of health screening routine.
Interesting. So I'm not sure, there's a question, it's not necessarily linked to this case, but I know it's your space as well. So Zolisile is asking about, maybe she's reflecting on that low CD4 count issue you mentioned related to obesity. And she's asking, so if someone has a low CD4 count, but they're suppressed, is weight management one of the things, or do we need to look at other things as well? Yeah.
Sorry, I'm not sure I understand the question. Is it on the chat?
Yeah, it's on 1912. I think is the 1912. Okay. Yeah.
So you mean if a patient's got a low
CD4 but suppressed, yeah,
and then they start to gain weight, would we be giving advice there, or should we preempt the advice? Is that the question?
Yeah, I think firstly, it's a clinical question in my view, how to approach someone who's not responding immunologically, but they are suppressed. And I'm not sure if, I don't know. It sounds, Zolisa, you may raise your hand and ask your question live, I think.
No, I think that's better.
So that we can try. And she also talks about SNAP and association with cervical cancer. She has seen a number of young women who are using SNAP with abnormal pap smears, having high-grade lesions. I mean, from a smoking point of view, I think that is likely, but I'm not sure about SNAP. Some risk is there, I guess.
So cervical cancer is related almost always. In fact, it is related to HPV. And I think that it's possible that there might be some dysregulation of the immune system. But young women who get high-grade lesions weren't vaccinated against HPV. Were unlikely to be vaccinated, and many of them are HIV co-infected. We discourage snuff. We don't like it. It's not so good for you. But I don't think that there's a link. Remember, you could say there's a link between carrying matches and lung cancer, but the actual link is that people who carry matches are usually smokers. So we just got to make sure that we're not taking two things together and putting causality.
Superb. Francisco is asking, okay, yes, DTG does lead to an increased weight, but he's asking whether there's an association between DTG and increased risk of diabetes. I haven't seen it, but I will hear from you. Yeah.
So I think it's one of those things that it's maybe a link in the chain, that obesity is associated with non-insulin dependent diabetes. And in fact, as I was sitting here waiting for the talk to start, I forgot to mention in my talk, I meant to drop it in somewhere, that metformin has an interaction with dolutegravir. And you can only really go as high as 500 milligrams. However, metformin is a very useful drug for the treatment of diabetes. So we've got to watch out for that. So I think that there might be an interim link, and there might be something, but management of weight is the cornerstone of much of this. If people are gaining weight and you think it might be dolutegravir linked, sit down with a patient and say, here are our options. There's not a one-to-one correlation, but shall we try changing the medicines and see if that makes a difference?
Superb.
I'm not convinced it does, but at least I think that what has happened with medicine as I've grown up is that we've got a much more, I'm not the demigod doctor. I'm the one who's got some information. Let's work together in improving your health.
Superb. I don't know, Sello is asking a specific question about treatment, to say the dose for Ozempic, 0.5 milligrams versus 1 milligram. I'm not sure if that's your space, Dr. Conradi.
I've forgotten it. I used to have it in my head. But with all of these drugs, the GLP inhibitors, is that we actually titrate the dose up, because guess what the major side effect is? Upper GIT discomfort. Of course, if you're slowing down the stomach emptying, you're going to get heartburn and dyspepsia. And one of the ways to overcome that, I can't remember the dose. Google it. Read the article in the Economist. I think that the story is not over. Our approach to obesity is finally changing to something that can actually help.
Interesting question from Zamalinda. She's asking about intermittent fasting or extended fasting. Are there any implications for HIV and any impacts on the efficacy of ARVs? She says most ladies want to lose weight, but they're not disclosing their status. So she just wants to know if there's anything she should be checking. Yeah.
So the treatment of HIV is antiretrovirals, and you need to take that every single day. And if you intermittently fast and only start eating, you can take dolutegravir or TLD with food or without food. It's no impact. If we just think back over the last 10, 15, 20 years, what advice we've given people around diet. It's intermittent fasting, and then it goes from that to snacking every 2 hours, and then keto, and then Atkins and whatever. So the bottom line is we don't have a clue. We know that if your energy intake is outstripping the amount of energy consuming, you will gain weight. But the actual finer details, I've been around the block quite a while. They're just fashions.
Yeah. Interesting. Tabisek is making a comment. She says the young girls use Snap to constrict for some sexual pleasure. Oh, I didn't know. Yeah.
Here or down there?
She says constrict, so it's probably down there.
Yes.
Tabisek.
Yeah.
Yeah, I don't know. I didn't know about that. Yeah.
But neither did I. I mean,
all right.
This whole issue around dry sex, using things to dry the vagina, which just makes it really unpleasant for women, is one of, I don't know if it's related to that in any way.
Yes. No. I think people are, issues of sexual pleasure. Just look at the emojis there. Suddenly people are awake.
Yeah. When I said down there, it was.
Yeah. Yes, Dr. Conradi, maybe your closing remarks, and then we call it a day. But to be honest, thank you, for this session. I think it's very important. And there's the national NCD framework with WHO. They've been visiting provinces. I was at least part of few provinces doing NCDs, hypertension guidelines, diabetes guidelines. And there was the emphasis as well between HIV and NCDs, and there's funding issues for the NCD program versus the HIV program, and there's all sorts of politics. I'm sure it's a space you are aware of. Yeah.
I think whatever field you're involved in, people want to say my field is bigger and more important than yours. The bottom line is that to improve the health of people who live in the communities that we serve, we need to do what we can to prevent HIV. When HIV infection has occurred, we need to ensure uninterruptible antiretroviral supply. And concomitant with that, our population of HIV-infected individuals is growing older. NCDs are increasing, plus the inflammatory basis for that. Don't be shy to talk to your patients. People are often so grateful when you say to them, you know what, you have gained a little bit of, you've gained weight. Should we talk about how to address that?